Hello there. Hello, my friends. I was supposed to give now a live presentation to you. I promised that yesterday. But the problem is, I forgot that I didn't bring with me my equipment to do that, like my ring light and the support for the computer, also the sound that I really like to prefer to do that with my own equipment. And also, here the connection is not stable. A good connection we have some from time to time, but it's not really stable. So I decided to do this way. Since I don't want to go back with my promise, I will do this way, and then I will open a box so you can uh, ask your questions, and I will be answering those questions during the day and whenever possible. Because I'm here in Dubai now. I will give a course later on. Look at this beautiful place that I am now, Dubai City. What a beautiful place to visit, huh? What a beautiful place to live. I love the city. And now I will wait a little bit because I need to go back to my to the meeting. And while we're here, I will do this. I will record to you. Then I will give to you the opportunity to ask questions, and I will answer all the questions. Okay? I'm sorry for not being live. I know this is the best way. I prefer to do this way also, but since I can't, I will do this. I asked a question yesterday on Instagram. Do you have doubts or something like a box with questions? And the most of the questions they were about this: how to run properly a diagnosis so you can understand what to do, and some questions about biomechanics, and in some cases then I picked this case so I can explain the interrelationship between these 2 points: what we do for diagnosing and what we do regarding the biomechanics to speed up our mechanics. This case I showed last month during the classes I gave, the free classes, and it's perfect for showing the proper way to link the diagnosis with the treatment planning and with the correct biomechanics. Some people ask me about the lines, how I draw the lines in my template, and I will try to do everything now so you can understand better, okay? So let me just set the time here so we can, yeah, let's move on. This is a patient of mine. Those who are in our last classes, probably remember her. I finished her treatment the day I gave the last class, and it's a perfect example of why we must do diagnosis, treatment planning, and biomechanics the proper way so we can our patient will benefit from this type of linking. In her case, what we see is mandibular deficiency. And this mandibular deficiency also is related to a lower anterior face height, a decreased lower anterior face height. And during the class, many people ask me, but why don't we just use the protocol of increasing the lower anterior face height in such case? And there is a reason for that. Let's run the diagnosis, and then I will explain during the process of the treatment planning and during the process of treating her with the biomechanics we chose for her. In her case, we have a symmetric face, symmetric commissure line also, lower anterior face height. This is one problem that I usually address, telling my patients the options. Option one, in her case, surgery. Would do a surgery for increasing the lower anterior face height by means of displacing forward her mandible, surgically displacing forward her mandible, and also the vertical displacement of maxilla in a certain way so we can have a better display of a gingival smile, a gingival margin during smile. In her case, you're going to see that we couldn't do that because he has a very movable lip, and I didn't want, and she didn't want also, to give her the surgical option just for the lip, okay? And we have the lower anterior face height, and also the lower third, this third here. This is a good option to show to you this. we have this link we have this lines here. They are linked, so we can move this way. And what we do now is position in the upper lip, so we can see what would be the best relationship to the lower lip, meaning the from the stomium to the menton. And you see that in her case we have this deficient, which is very common in mandibular deficiency, real mandibular deficiency. I don't mean just the convexity of the face, but the deficient mandible in size, a short mandible. So this is very common. The other thirds are also linked together, so we can put and try to find the best relationship. So we have a lower anterior face height decreased, and also this volume of the face is decreased, which we see that very frequently also in patients like this. A lower anterior face height with a very short volume in relation to the other thirds, and this volume, it's something that with time will have its cost, which is will give more age for the face. And this is also discussed with the patient, so patients can understand what are the problems now and what we are thinking about the future. In the future, what's going to happen? If I think that nothing is going to happen, she's okay with this, and it will be pretty stable, I just mentioned. But I need to tell my patients what are the consequences of not doing this type of correct, let's say correct, because I think it is correct way to manage it, which is the surgical procedure, the surgical choice. She dropped it. I don't want to do that, Kleber. I want to do something different. In the beginning, I remember the first consultation we had, she was like, okay, I want to do the best. I want to do what you tell me is the best option for me. But she eventually, during the first 2 or 3 months, gave a time to think about it better, and she just quit of this option. She told me, Kleber, I'm a little bit confused, started this way because I'm thinking about the post-surgical, what is going to happen post-surgically. Am I going to be pretty satisfied with that, completely satisfied? And I'm thinking if the other option you gave me, maybe I will have a better smile. And that's something that, so on and on and on, and it's very common in our daily practice. And she dropped. I don't want to do that. Okay, so we are going to do the second option. If I thought that the second option wouldn't be a good thing to do, like I will treat you, but by treating this way, the outcome of this treatment will be bad for your smile, bad for your face, bad for the function, I wouldn't treat her. But I know that I can centralize her upper midline, which is the main complaint she came to me with. She knew about the mandibular deficiency, okay, but she didn't really sought treatment based on this problem. Mainly the upper midline shift towards one side. And we addressed this during our treatment planning and during our diagnosis process to show to her the options. Moving on, we have it here. I will do that by this way so you can understand how we are doing this. So we are going to superimpose the photograph, intraoral photograph with the extraoral photograph so we can match the upper and lower midlines. We see the relationship between the upper and lower midlines so we can understand what we want to do. Upper midline deviated, shift towards one side, lower midline also deviated towards the same side, but less deviated than the upper. That's it? Yes, to the left also. And going on, this is an asymmetric positioning of upper canine, which is obviously why her midline is shift towards one side, and I want to approach this so I can have a better positioning, symmetric positioning of the upper canines. And we go on with our treatment, with our diagnosis. Buccal corridors are not that bad, but we have lingual inclination of posterior teeth. We don't have a deviation in the occlusal plane. which is very good because this is something that's very pretty difficult to control in some aspects, in some situations. So I prefer to not have this. We have the profile analysis now. As you can see, the profile analysis shows a big convexity of the face, and the convexity of the face is one aspect of the problem. From that point, we must understand where it's based, where the problem is really located. Because we can have a problem in the maxilla, in the mandible, and lower anterior face height increased without a really short mandible. So all those aspects will drive a specific solution for them. And this is why I need to understand where the problem is located, okay? We have also here the nasolabial angle, good nasolabial angle. I don't think I want to change that, or if I need to change that by retracting anterior teeth, I will do that by means of controlling the torque. So I will change that maybe sometimes negatively. We can change that with a little bit of opening of this angle, which is not that good in most of the class 2 cases. But when we have a good maxilla, of course. But by changing that, I will not do a huge change. I will not do maybe a visible change. This change is okay. We see that when we do the comparison, we call the comparison, sorry, the before and after, the comparison between we see before and after, and we see there is a change. You'll see that. But this is a change that will not affect negatively her face, badly her face, okay? Good nasolabial angle. The mandible is retruded in relation to the maxilla, and we see that here, which also exhibits anterior posterior deficiency. Maxilla is also deficient, but not that much. And the mandible is deficient in relation to the face and then in relation to the maxilla also. The chin neckline is short because of two reasons. First, a short mandible. Second, a vertical displacement of the mandible. So we have both the mandibular is down and also the short distance between the condylium and the amentum is showing a short mandible in size, okay? And in this case, I will do nothing without surgery because I don't want. What is the option here? So this is the point I was trying to show to you. People during the course asked me, I showed some cases in which I increased the lower anterior face height in patients with short lower anterior face height. And those cases are different from this one because those patients, they had a good mandible in size. The mandible was good. The problem in those patients, really, the problem was the lower anterior face height because of the counterclockwise rotation of the mandible. In this case here, we don't have it. We don't have it. We have a short mandible and also a short lower anterior face height. And if I increase it in this size of mandible, I will give more convexity to the face. In this case, I can't do that. I don't want to do that. And this is something that I must consider. Another thing that people ask me about this case here, what about, because you'll see that she ended up with a little bit of gingival smile, gummy smile, because she has a movable, very movable upper lip. So the mobility of the upper lip in her case is high. And she really shows gingiva. But look at this. Look at the relationship between the upper incisors tips and the stomium. It's negative. So I couldn't intrude much those teeth because this is something that she wouldn't show during the speech. Meaning I will not do that because I must consider this relationship. Don't know if you're completely understanding that, but maybe it's going to be more clear with that treatment planning. And we have the upper lip in front of the lower lip, a long distance between them, and the lower lip behind the line between the pogonium, the soft pogonium, and the subnasal. Okay, And we see that as a reference to understand what to do regarding the torque. This is a good line for understanding what to do with the torque. Also, she has this mandibular deficiency, pogonium deficiency also. There are different ways to see in this type of line. I like the line, and sometimes I just do this line to understand the relationship between the lower lip and the pogonium. I know this is the more procumbent lip will be the reference, but sometimes we use the lower to see if it was a surgical case, I would use the lower because I would, from this point, make sure if I need or not to do the genioplasty in her case. But it's not a surgical case, so I'm not using this way. I'm just wanting to understand this problem, the dental problem. See here, I can't do much of intrusion in her case because she already has a negative relationship according to the functional aesthetic occlusal plane, which is a measurement that I like from two friends from Brazil, Carlos Alexandre and Renato Martins. We also have the lower, in relation to the stomach, the lower incisors. We can change that. This is the panoramic X-ray. And this is interesting. Now look at this. It's something that will help me now. This one here. Look, we have 3 molars in this side. And we have 2 molars in all other sides, which makes me think about something. You already know, the upper midline is shift towards left. So I have something here, a backup here. I can use that molar. And look, pretty clear, huh? Pretty clear for us what we need to do. We go on. This is the relationship between canines in an occlusal view. So the molar can be extracted, so I can have the retraction of that side. But you look at this. I'm not afraid in cases like that to retract because I don't have really space to retract here. I have a full step class 2 in the relationship between upper and lower canine. I must go from this point to this point. But for given this rotation of the arch, I must provide torque. So the torque will compensate for the retraction that I'm gonna make, okay? That I'm gonna need to do. And I have the molar which molar are we going to extract? Of course, not premolar because she has just 1 premolar. And this is very odd in smile when we extract 2 premolars because she had already extracted 1 and in the previous treatment. So 2 premolars extracted one side, putting the canine in contact with the molar for the smile is pretty bad. I really don't think it's something that you want to do in such cases, okay? So we have here the option to do the extraction of the molar instead of premolar. And this is what we did. We do the sequence of arch wire. Remember, because we have time here for focusing on this case, I want to explain all the aspects that come to my mind now. One thing, I will do the torque. I need to do the torque so I can give space before initiating the retraction. Yes, I will give for her more upper lip, then I will steal a little bit of it when I do the retraction. But for that, I need to use torque. The problem is when we use torque in brackets like this, in braces, ceramic braces, they break too much, they break a lot. So what I advise you to do is this. Always use TMA for such situations. TMA 1725 is a good option for giving the torque. It will take longer for expressing the torque, but this is our option. If your patient want to use the ceramic braces, I don't think I can say something. I see people say that. I don't care if they like ceramic braces. This is not my option. I won't do it. But we need to do that. We're treating people like us, human beings. They have their own will. This is not something that I can do. I'm not going to give to them my only option. I'm not giving to them one option to treat. I sometimes see, and sorry for that, but I think it's completely wrong. But if you do that, maybe you think it better if you say, I don't use aligners, or I just use aligners, I don't use that, I don't use this. We are in this profession here to help our patients the best way we can using all the tools we have in our toolbox. And we are going to choose That from that toolbox, we're going to choose the best options that we have for giving to the patient the fastest treatment we can, the safest treatment we can, with the best finalization of the case. And this is something that we can only give to all our patients. I'm not saying that one case, two cases, even 100 cases, yes, you can use that type of device of your choice, but you know that in those cases, in some situations of those cases, if you put something else, if you put and give another device or another choice during the treatment, you would be faster. So I know that you can use, I know that some people just want to use aligners. I know that some people don't use aligners in no situation. Some people prefer to use, some orthodontists prefer to use ceramic braces. Others prefer to use just metallic braces. Others prefer to use just self-ligating. And those are just options. Those are just devices and tools for treating our patients. They are not the treatment. The treatment comes from your mind, your treatment planning, okay? So this is what I want to tell you. This is tough. Yes, it's tough. I can't have a good torque the same way I give the torque with the metallic braces. My role in this process of choosing the bracket is telling my patient, this wouldn't be my first choice. Why? Because I know that I will need to apply a huge torque in anterior teeth, and by doing that, using ceramic braces may be tough. Maybe I will take longer than necessary. And she will choose. She told me, but I'm 50 something. I don't, I don't remember her age, and I don't want to say it. But I don't want to be again using metallic braces, in metallic braces. I want ceramic. Is it possible? Yes, it is. So if you understand that it may take longer, I'm here to help you the way I can, okay? But consider that it may take longer. You see, that was not that much. The case was very fast, pretty fast. If we take into consideration the magnitude of the problem, it's pretty fast treatment. And here we have before initiating the retraction. So before I do the extraction of the molar, I will reach the rectangular arch wire, then I'm doing the torque in rectangular arch wire. Even using the TMA, sometimes it will break. You see here, the torque is there, not a huge torque, and there is an active torque. You see the lower part of this gap here is because we have the contact in the outer part of the wall in the upper direction. In the lower part, in the inner part of the slot, we have down, the force going down. So this is what we have here, the torque. But look at that. Ceramic braces are ceramic braces. The best ceramic braces that we're using, they will have some difficulties. Some of them are very strong, and when we bond, to debond is difficult. Some others, they have problems with the slot, others with the shape of it. So ceramic braces are maybe tricky, but we need to work with them sometimes. Another breakage here, another time. Look, but we are gaining our space here. We are conquering our space here. There is room now to do the retraction, to initiate the retraction at least, and this is what we do. After giving the overjet, now I will retract. And I did the retraction using a compressing loop and the delta loop, and also a TED, so I can help the retraction to take place. In this case, I'm losing anchorage of the molar, trying to give a more translatory movement to the molar, but it's pretty difficult, as you know, especially in the long distances. So sometimes we wait, we don't reactivate the loop because it's not helping us. If we do that, we are going to have a very fast space closure here, but also with losing inclination in the anterior segment. Look at that. Lost inclination, and then I have the contact. I'm still in need to do the correction here, okay, of the midline. So what I'm doing now, more torque, and in this case, because I wanted to do something to the molar, also to the molar to correct the angulation of the molar, I could benefit from this type of mechanics that I'm going to explain to you. So this is the third the leg of the tripod, the biomechanics. Now we insert the biomechanics in this process here. What am I doing now? I am doing putting here a cross tube so I can have a two-couple system. What I want now is just to wait to have the correction of the molar and the correction of the anterior teeth, increasing the overjet, increasing the inclination so I can go on with retraction, because I need to correct the class 1, the class 2 that I have into a class 1 by retracting the canine in this side and correcting also the midline in the process, during the process. And now we are just measuring. What I want here is to give to the system an equilibrium in the vertical forces. How can we do that? For avoiding extrusion or intrusion. How can I do that? I will use a specific geometry for that, which is the 6th geometry. I will balance the angulation between upper and low, between anterior and posterior segments. So I give the truncated V to the system. We don't have much time to explain that, but if you have doubts, you can approach me, or you can go to my videos or an article that I have showing this. Okay, so we measure. This is force-driven mechanics. We measure posterior and anterior forces when we go down with the tip of the wire. This is strip of wire that I just did the contour, and the torque in anterior and posterior, meaning the couple in anterior and posterior, and they need to match in force. In posterior, this is the force, and in anterior must be the same force. So the level of activation of this must be the same in anterior and posterior. And then we cancel the vertical components that are acting in the same body. Look at this here, is going down and up with 50 grams because of the, all the physical laws for that. So you understand that we have the action and reaction forces, the activation and the deactivation forces, the equilibrium forces. So we have here in the system the vertical forces canceled. And now we have just the moments. This is what we want. I really want that to happen. So in this case, I have the moment in anterior segment going buccal, and posterior segment uprighting the molar. And what do I want to do here? I don't want to have a free rotation of the molar with the couple, because in that situation, generally speaking, we have the center of rotation being the center of resistance, because the vector, the couple is, the moment of the couple is a free vector. And in this case, being a free vector, applying in whatever situation, the center of rotation would be the center of resistance. It's not quite true, because we have a restrained system here. It's not a free system, but I want to profit from this type of movement of uprighting of the molar without letting the crown go distal, because I already closed the gap. So I will cinch back, so I have more effect on the root than in the crown. So I will really change the center of rotation of the movement, going from the center of resistance down in the direction of the tube. This will help me to go mesial with the root without going that distal with the crown. Okay, that's what I want. That's what I'm aiming at. Okay, here it is, day 1. I want to do this torque, and look at that, 1 month later. Coming again to this point, and we have 1 month later this. So this is segmented here, just attached with this ligature, steel ligature, and posterior teeth with the uprighting of the molar. And after a while, I was able to go on with the retraction. So we go on with the retraction, and of course, nothing is perfect in this type of movement, long movement to be made. And again, I will stop a little bit my mechanics here to upright the molar. using the same strategy because I have an almost edge-to-edge situation here. I'm doing again the torque in anterior, correct in anterior, and using the V shape again so I could correct also the angulation of the molar. You see what I'm doing here? If I did like using that mechanics, straight wire mechanics, closing the gap, losing inclination, I would take much longer than necessary to correct everything. And in this case here, I'm using this strategy so I can have a faster movement, not stopping everything. I'm correcting one and helping the other part to be correct, also using the same strategy. You know, this is mechanics. This is biomechanics. I know what I want. I will try to devise here the best mechanics for that. I will try to identify where the problems are located, what are the solutions for that problem, specific problem in the other part. And here comes another advice for you. You need to do that. Take pictures of your cases. I don't say every time because there are some cases that are pretty simple to be treated. And but cases like that, like this one, they need to be followed very closely. We must see what's going on in between the consultations, between the appointments. If we see what's going on, sometimes we just stop what we are doing and we plan it again. We do something different. We change our strategy. And the only way to understand this is by seeing. You are not going to remember what happened between the a span of 4 months. What happened during this 4 months? Do you really remember? But if you see, if you analyze, if you stop, if you try to anticipate the problems that are going to be generated in your mechanics, you can have a richer mechanic in those cases. So take pictures, take photos, okay? That's it. And going on, you see I'm waiting because torque takes time. We all know the 3T rule, torque takes time. So it goes on. And since I know, oh, there's another thing here. Oh, it's a good thing when you have time, huh? When you have time to discuss thoroughly one case. In this situation here, of course, I want the torque in the anterior segment, torque in the anterior segment. I'm like this, I'm always doing that. So in my mind, you can understand better when I do this type of weird thing, torque. And in the posterior segment, I want the angulation of the molar to be corrected, okay? And doing the torque in the anterior segment, there's one side effect to the torque, which is the rowboat effect that will give the inclination of anterior crowns to be more effective than remodeling, resorting the bones, or remodeling for the movement of the root. You know that. So it's easier to go forward than to go distal with the roots. I have several videos showing that, and the video, I think it's a pretty simple way to understand this. Actually, I was talking to a girl from Jordania, I think Jordania, that she told me, I did that article. My friend Mo Muzian actually reviewed that article in some way. I don't remember where, but she told me, Prof, look, this article I did this way because of your video on the rowboat effect. And it's interesting because it's visual, huh? The way we see things. I struggled a lot to try to show people what the rowboat effect is about. So I did that by this, using the video. So it's pretty much simpler to understand this way when we see the video, the contact, the movement intended, but the real movement's not that. And I think it's easier for us to see things. Okay, I'm just philosophing. Look at that. We have time here, so to avoiding the rowboat effect, what I'm doing, I'm securing the anchorage here, because if I didn't do that, the canine would eventually go forward again. And I'm using that at least 12 hours a day. And don't tell me your patients, don't want to be compliant, because maybe you're not explaining the whole process to them. When I explain, because I charge for the treatment, they come again, they are not doing anything, they are not wearing the elastic, and tell them, you are now paying me for nothing because you didn't wear the elastic. Now again, I need to go back to what I needed, or if you don't want to use the elastic, wear elastics, I have other options. We can insert here another tab, we can insert here a mini plate. It's expensive, but it's possible. If you don't want to wear the elastics, I have other options. But if you tell me that you are wearing the elastics and you are not, you are really not doing a good thing to your pocket. You're going to pay me again and again and again, and it will take longer, much, much longer than necessary. And maybe I will not be able to finish your case the best way I can. Simple. Direct and simple. Do that. Try to do that. And tell me. Especially if you have young kids treated this way, being treated this way, you see that their parents will say, yes, he's going to wear or she's going to wear the elastic. I will make sure that, and they will wear. Look, we are finishing with torque. Again, the TMA back to the position and doing the torque, and I finished the treatment. I don't really remember the time of this. I will make sure that I think less than 1 year and 10 months, something like that. I don't remember right now, but it was for this case. It was fast, because I needed to deal with the torque a long time because torque takes time, and after that I did the extraction of the molar, did the retraction of this huge space. For us as orthodontists, it is huge. Yes, we have some drawbacks here. We have some case. We have also many things to do after debonding. She was referred to the veneers and the periodontologist, so we can finish things perfectly, as perfect as we can, of course. And that's what I want to show to you in this situation. So we can do all of this based on solid diagnosis and treatment planning and solid biomechanics. Don't do things just based on, I think that maybe I do this, and when I realize it's wrong, oh, maybe. No, don't do that, guys. This is wrong. This is something that's not fair with your patient. Your patient is someone's son, is someone's mother, is someone's father, and I treat my patients this way. I always tell my students to do the same thing. We must treat our patient as if they were our own kin, our own son, or mother or father, okay? Because I want to give to them the best that I can, and I will struggle to do that. I always, another thing that I advise to my students is practice a lot, because when you need to do something, don't procrastinate. If you are not practicing, you will procrastinate. Let's say you have a patient to do a loop, whatever loop, a torque, whatever torque, and you are like in one lazy Friday, 5:55 p.m., and you have 3 more patients in the reception and the waiting room. What are you going to do? Are you going to really to do the torque if you don't know how to do it, if you're not practicing enough? Are you going to do the loop if you don't practice, if you are taking 10 minutes, 20 minutes to do a loop, a correct loop? You're not going to do that. But if you practice enough, what's going to happen? You don't even think, I need to do that. I will start doing that. And I'll need to do that fast. And we know how to do, because we did that a lot. The golden rule is the 5,000 times rule. You need to do something at least 1,000 times, 5,000 times, so you can be good at it. So here, go on, helping the movement with lingual buttons and power chains. Yeah, and going on. Okay, we have 5 months after initiating the space closure. We have 6 months after initiating the space closure, and we have the case before and after. what we did here, okay, a little bit of distal displacement of upper lip, but it was the price to be paid. She knew that, but in general, we have a good relationship between upper and lower lip, better, of course, not perfect. And I also gave her the option of a genioplasty, and she refused also, because she's satisfied with what she gets after treatment. Okay, so we have before and after, and before and after. It's perfect? No, it is not. Gingival display? Yes, we have. But we couldn't do intrusion in upper because what we saw in our treatment planning, okay? So if you look at this, like people told me, but she still has a gingival smile. Okay, my bad. But I based my treatment and by my biomechanics on that solid diagnosis and treatment planning. So guys, we are approaching 45 minutes of class now, which is what I planned for. And that's it. I'm sorry for not giving this live class to you. I must call your attention about one thing. We still have our course, but we will be soon closing the enrollment for this course. So don't miss this opportunity if you want to learn more about it. You know me. You know that I genuinely believe that I can give you a way to treat your patients better, and I do that by means of those courses, online courses. Since I can't reach everyone everywhere, I'm here in Dubai today, but I'm going back to Brazil, then I'm going to Egypt next month, and it's just for groups. And I have every day hundreds, believe me, hundreds of orthodontists approaching me, asking me about some type of treatment, some type of diagnosis. And with time, I understood that I can't do that my entire life. If I do that, what I do now? I give the course, look at that, I have this. If you want to understand it better, because I can't start from one point. People ask me, what can I do in this case? And show me just the casts. And it's difficult for me to tell them, look, I can't say what to do just looking at this two casts that you're showing to me. You need to understand that the diagnosis, the treatment planning, and then the assessment of the treatment planning and the diagnosis during the treatment, they must be complete. So that's why I'm doing this today. I think I can help people to understand better biomechanics, to understand better diagnosis and treatment planning this way. And I'll leave here the QR code so you can see the course again. I'll leave here the QR code so you can see what we have in this course, and we have a promotional price for a limited time, and it's almost coming to an end. So don't miss it, okay? Guys, very good to be with you. Again, look at this beautiful city of Dubai. I'm in love with Dubai. Let me see if I can show to you here. Yes, I think I can. Look at that building there. Do you remember Tom Cruise was there? Okay, outside of the building, if you remember well. Remember the movie? So guys, thank you. So guys, thank you a lot for being with me. Again, I really appreciate you sending me messages saying, Prof, thank you for this, thank you for that, but I do that from my heart. When I have the opportunity to help people to do things better, for me it's better because I've been seeing the results for a long time. I'm really satisfied with this, okay? Thank you very much. See you soon. Bye-bye. I'm here in Dubai, and I want to tell you something, Tom Cruise. You're not the only one to go outside of the buildings here in Dubai. You have brave men doing that. Look at that. You see? Not just you.